Here we go.
Good morning, everyone. My name is Katharina Janda. Thank you so much for being here, and thank you, AMIQT, for the opportunity to present today. Today's presentation will be about craniopharyngiomas with a special focus on the neuropathology. The contents of this presentation will include a quick overview of the definition of craniopharyngiomas, the two clinical pathological variants, the epidemiology and clinical features. I will go over the most prominent imaging findings and the most important diagnostic tests. After that, we'll have a deeper look into the neuropathology of those tumors and discuss all the therapy options. Towards the end of the presentation, I will explain the most important differential diagnoses to know, and also the prognosis. And to finish off, I'll give a quick outlook on regarding prospective developments. So craniopharyngiomas are slowly growing benign tumors of the stellar region. They are derived of remnants of the Rathke's pouch epithelium. The pouch later on forms the anterior pituitary, as you can see in the figure. And you can also see the remnants of the pouch right here in that intermediate part. Those ectodermal derived epithelial cell remnants then undergo a neoplastic transformation, which also explains the squamous morphology of those tumors. And until last year, the WHO classification of CNS tumors recognized two subtypes of craniopharyngiomas. But since there was an increased molecular evidence, which I'll explain later, these are now considered two separate entities. I will still go over both in comparison to give you a thorough overview. Okay, at this point, I want to give you a quick overview of the two variants. I will give you a quick summary, but I will go into detail later on. So the two clinical pathological variants are the adamantinomatous craniopharyngioma and the papillary craniopharyngioma, the ACP and the PCP. The ACP is solid and partially cystic and has a distinctive squamous and palisading epithelium combined with a looser stellate reticulum. It almost always has a CTNNB1 mutation, which leads to an overexpression of beta-catenin, which is a protein that regulates cell growth. The papillary craniopharyngioma, on the other hand, is characterized by a non-keratinizing squamous epithelium that is surrounding fibrovascular cores. It usually shows a BRAF V600E mutation, which is a very common cancer-causing mutation. Craniopharyngiomas account for roughly 1.2 to 4.6% of all intracranial tumors. The adamantinomatous variant is way more common and makes up around 90% of all craniopharyngiomas. It occurs more often in children aged 5 to 15 and makes up around 10% of all intracranial tumors in that population. But it has a bimodal age distribution with a second peak around 45 to 60 years of age. As you can see here, that's the first peak and that's the second peak. The PCP, on the other hand, occurs exclusively in adults, as you can see here, but it's still less common in that age group than the ACP. Okay, we'll now go over the most important clinical features. Most of them overlap, but some are more distinctive for one variant. Patients most commonly present with visual disturbances, especially bitemporal hemianopia. Patients with ACP can also present with endocrine deficiencies. Especially children can develop endocrine dysfunction before they develop any other symptoms, which usually presents a growth failure and delayed puberty, which is because the growth hormone and the gonadotropins are most commonly impacted. Those patients with PCP, on the other hand, rather present with hyperprolactinemia, which is due to the pituitary stalk effect, which inhibits the transportation of dopamine from the hypothalamus to the pituitary. Patients with ACP can also present with diabetes insipidus. Further shared features include the cognitive impairment and personality changes, which occur in roughly 50% of patients. and also the obstructive hydrocephalus, which is due to mass effect. Okay, the most important diagnostic test is definitely the MRI, although the CT is also sometimes used. Furthermore, every patient should undergo a full pituitary endocrine workup, and also visual field testing is very important. I will now discuss the most prominent imaging findings of the ACP. It most commonly has a supracellular location. Sometimes it also has an intracellular component, and it frequently extends into neighboring structures. It has solid and cystic components, which provides a multi-lobulated appearance. On the upper left picture, right here, you can see an MRI flare sequence, and you can see the cystic and the solid component in a supracellular location, and it's causing obstructive hydrocephalus. The post-contrast coronal and sagittal images very nicely depict the lobulated appearance. They also show a mild enhancement of the solid component, no enhancement of the cystic component, and very strong enhancement of the cystic walls. ACPs also very commonly have calcification areas, but those are better seen on CT scan. So now in comparison, the imaging findings of the PCP, it usually presents as a solid mass, which has a supracellular location or lies in the third ventricle. On the right picture, we have an MRI T1 with contrast, and it shows a strongly enhancing solid lesion in the third ventricle. The other picture is also an MRI T1 with contrast, but now sagittal, and it shows a vivid enhancement of a solid lesion in a supracellular location. Okay, coming up to the neuropathology part of the presentation, I first want to discuss the differing macroscopic appearance of the two variants. As mentioned before, the ACP is a lobulated solid mass with cystic components. Those cysts are yellow to white, and they contain a very dark greenish-brown fluid, which resembles motor oil and is rich in cholesterol. Secondary changes such as fibrosis, calcification, ossification, and cholesterol crystals are also very commonly seen. In contrast, the papillary craniopharyngioma is usually solid. It is very rarely cystic, and if it does have cystic components, they would be filled with a clear fluid compared to the ACP. The surface of the PCP is corrugated, or one could say cauliflower-like. Okay, here you can see a macroscopic image of the ACP, and you can see very nicely those solid components compared to the cystic components. And you can also see that the cystic components are filled with that motor oil-like fluid. Okay, now I will go over the histology of the ACP. The tumor is composed of compact sheets, nodules, and trabeculae of squamous epithelium, which shows peripheral nuclear palisading. And those more densely packed cells are then combined with the more loose cells, which is called the stellate reticulum. Degenerative changes form the cystic spaces, as well as the cholesterol clefts. And the key feature to know here is the so-called wet keratin, which is an amorphous mass of cells. It's made up of squamous cells that like nuclei, and those can also later calcify. ACPs, like mentioned before, have infiltrative borers, and those are associated with gliosis of the surrounding tissue and show also Rosenthal fibers. This should not be mistaken as an pilocytic astrocytoma, which also commonly presents with gliosis and Rosenthal fibers. Okay, here on the left, you can see the trabeculae and in between the cystic spaces of the ACP. And on the right picture, indicated by the arrow, we have the wet keratin. And as you can see, it doesn't have any nuclei. It's an amorphous nest of cells. And you can also see the more dense squamous cells compared to the very loose microcystic stellate reticulum. On the left picture, you can see very prominently the many cholesterol clefts with a spiky appearance. and also the darker areas of calcification right here. And on the right picture, we also have some cholesterol crystals. We also have some pigment deposition, as you can see here in those darker brownish appearing areas. And that pink tissue is reactive gliosis. Okay, now in comparison, the histology of the PCP, like the name already indicates, it has a papillary architecture. The key feature here is the fibrovascular course surrounded by the monomorphic squamous epithelium. T cells, macrophages, and neutrophils can also be commonly seen throughout the fibrovascular course. And rarely, we also have a ciliated epithelium and PAS-positive goblet cells, which are usually needed for the to produce the protective mucus layer in the intestinal wall. Okay, here on the left picture, you can see very nicely that cauliflower-like appearance. And if we zoom in a bit on that fibrovascular core right here, you can see that it's surrounded by those very monomorphic squamous epithelium. Okay, here on the left picture, we have a fibrovascular core that is filled with many immune cells, indicated by those dark spots, which indicate inflammation. And here on the right border, we also have some goblet cells, as you can see here. The right picture is the same specimen, but now depicting immunohistochemistry, which is positive for BRAF V600E marker in the squamous epithelium, as can be seen here by that brown coloration. And that's it for the neuropathology part of the presentation. I now want to go quickly over the therapy options. Preferred is a total surgical resection, which is curative. Some lesions can be assessed by a transsphenoidal approach. As seen here in that picture, it's through the nose. Others might require craniotomy. If only subtotal resection can be achieved, which is common with the ACP because of those infiltrating borders, it should be followed by radiation therapy. Radiation therapy is also very useful for cases of recurrence. And specifically for the PCP, we also have the option of using anti-BRAF agents like dabrafenib, because those can also induce shrinkage. Okay, regarding the prognosis, the most significant prognostic factor is the extent of the surgical resection. Since recurrence is very common, like mentioned before, especially with the ACP, because of the remaining tumor cells due to the microscopic infiltration. That is also why PCP has a slightly better outcome than the ACP. Also very important to know for the outcome of craniopharyngiomas are any remaining endocrinologic deficiencies, which might require continuous hormonal replacement therapy. Craniopharyngiomas very rarely undergo malignant transformation. Generally, patients with an advanced age and a very large tumor carry a worse prognosis. Regarding the most important differential diagnoses to know, the most important to know are the epidermoid cysts, which is a uniloculate cyst with a thin layer of keratinizing squamous epithelium. Also important to know are the Rathke's cleft cyst with a squamous metaplasia. Those are usually cystic without any solid components, but they can have a squamous epithelium which is ciliated and can contain mucus-containing cells, which is why it can be confused with the PCP. The pituitary macroadenoma is also very important differential to know due to the similar location, although it's usually more intracellular, as can be seen right here on the picture on the right. And the ACP, like mentioned before, can be confused with the pilocytic astrocytoma because they both show the gliosis and Rosenthal fibers. Okay, and lastly, I want to give you a quick outlook on what's potentially to come and on what might be interesting to know regarding the future therapy of craniopharyngiomas and also other tumors. Instead of the conventional radiotherapy, nowadays there's also the possibility of using a proton radiotherapy, which uses a proton instead of a photon beam. And since protons are particles and not waves, they can penetrate matter to a very specific depth, which provides the possibility of concentrating that energy to a very specific point. This is called the Bragg peak phenomenon, as you can also see here, which can reduce the damage to the surrounding tissue to a minimum, especially compared to the conventional X-ray therapy, as you can see in the figure right here. The efficacy is very similar to conventional radiotherapy, but it reduces complications that can occur due to the radiation of healthy surrounding tissue. Okay, and then with that, I've finished my presentation about craniopharyngioma. Thank you so much for listening, and please feel free to ask any questions that you might have. Thank you.